Anyways, I just want to say that I can't say enough how delighted I am to be here. I do remember, Perry, when this was a gleam in your eye, you know, and I am just in awe of the work that's been done these past 10 years in bringing together a community that's truly has been in need for understanding, compassion, and effective ways out of their health. So we're all part of that today, so I'm really, really glad to be here. So let's see how this works. Okay, there we go. Oh yes, I have to tell you, I have to disclose all my conflict of interests and other disclosures. So first of all, I do work for, I am a consultant for behavioral tech, which is owned by the Linehan Institute. I do teach with Marcia and do work on implementation of dialectical behavior therapy. I have some other things to disclose. First of all, I'm talking about pharmacology appointments today. Sometimes people ask me about drugs, even though that's not what I want to talk about, is which drugs you use. So I just need to make sure you know that any medication, there is no medication approved for borderline personality disorder, so if I discuss a medication, it will be off-label. I have some other things to disclose, so we might as well get these off the table right away. I am 53, and if you don't know about the concept of a sacrifice cake, you should talk to my teenage boys. Apparently, when you're this old and you put all the candles on the cake is unedible. So you have to have a second cake. And then last month, I bought a cigar for my 15-year-old. He's right there, and he was being taught how to smoke cigars by a friend of mine, and he did throw up. So, a couple other things. I have a 13-year-old who I apparently annoy, as you can see. And although I was Minnesota Psychiatrist of the Year, what I really wish is that I could be the Dairy Queen, Princess K of the Milky Way at the State Fair, because she gets her face done in a butter bust every year. And honest to God, if you go to the State Fair in Minnesota, you can't believe it. You can watch the sculptures carving the butter busts of Princess K and her maidens of honor in a refrigerated room that's all glassed. So you can walk around and watch them. So I don't know, maybe someday. Okay, it's good to get that off my chest. You know, so there was three things that we were going to talk about today, kind of just to remind you of what the objectives were. I was trying to figure out how to describe the therapeutic tools that I use within the midst of delivering psychopharmacotherapy. In other words, I'm prescribing medications, but what I'm doing in it is how I go about it with the patient, and how do I pull out functional behavior and, at the end of it, a better relationship between me and the patient and a more likely chance that what we're doing is going to help. So I thought I'd go about it by framing pharmacotherapy in what we call the functions of treatment in DBT, and then talk a little bit about how I organize the session. In all behavior therapies, we use target hierarchies. And finally, to try to weave in a little bit about the principles of the treatment that are used between me and the patient. You know, it's a 524-page treatment manual, and I have less than an hour, so it was a little bit of a challenge. I know some of you are DBT practitioners, some of you are not. So I'll do my best to convey the sense of what I do in these appointments with my patient. The other comment I want to make is to refer back to what Dr. Sledge said. I have to tell you, the only reason I do DBT was very practical. I've been in public health my entire life. My whole career has been devoted to public health. In 1994, the state of Minnesota, Department of Human Services, hired me to figure out how to help them with all these individuals with borderline personality disorder who were getting committed against their will into state institutions. And I said, I like a challenge, and this is a group of individuals that I was interested in. And so in '94, I did, as a public health physician, I did what I thought a public health physician should do, is find out, is there any data of anything that works? And in 1994, the only randomized controlled trial of a treatment that seemed to be effective was dialectical behavior therapy. I didn't know what the word dialectical meant, I'm afraid to say. I'm sure everybody at Yale knew what it meant. I trained in Oklahoma, what could I say? You know, I had been trained by analysts and had 5 years of psychoanalytic supervision. So I didn't know anything about behavior therapy, but what I knew was this article said that this worked, and I was in public health. So do you see how I ended up there? I think the spirit I want to say is how thrilling it is to me that individuals and families have choices of things that if something doesn't work, you can try a different approach, and that clinicians do. Because it turns out clinicians do treatments effectively when they like the treatment they're doing. So more power to us. I mean, I really mean that. One last thing about what I want to say here is that not only am I thrilled to be here, but one of my patients donated his diary card for y'all today, and it's in the extra handouts. And he gave me permission to use his first name. His name is Adam, but he said, I have to read you a statement. So I wrote this down in our last session. And Adam is both someone I do pharmacotherapy with, and I'm his individual DBT therapist. And he said, okay, tell them this is from one of your students. Now, isn't that sweet? I'm his therapist, and he thinks of me as his teacher. I just was like, I mean, my little heart just went like this. He says that he wants you to know that he's been working hard in DBT, and it's been a roller coaster for him, but he does not give up, and he wants everybody to know they should never give up. He says, I want to give a shout out to all the people in the room who have borderline personality disorder. Remember, every day is a new day. Try to stay in the moment at least one time each day, and remember, you can do that. You can do this. So that's Adam, and he says he wishes he could be here too, so thank you, Adam. All right, so in dialectical behavior therapy, the treatment's overarching goal is always to get the person to the life that makes life worth living for them. Everything else is about sorting things out and getting either things reduced that get in the way of that, or aspects and behaviors about within yourself as well as in the people you live with that promote you getting there. So with that in mind, pharmacotherapy is a piece of a clinical tool within that. All right. So the other thing that I like to remember, too, is that there really are 3 ways biological organisms change. And so if I'm trying to help someone get from the hell that they're in to out of hell and beyond, there's 3 ways I can see that they can do that. One of them is something that I don't necessarily have control over, which is maturation or development. We start out like this, and then we end up here. And then we end up spending money with dermatologists and stuff, but that's another story. But that goes with number 3. You can do chemical alteration or direct manipulation of biological systems, which is where the pharmacotherapy lives. And then where all the other interactions that I do, even if I'm only being the pharmacotherapist and not the primary therapist, is I know that we can change through experience, which is otherwise known as learning, and is the idea of harnessing the principles of learning that are occurring all the time. It's like I say to people, the sun is always shining, right? But if you actually understand how it shines, you can build solar voltaic cells and direct the energy. So it's the same thing with learning and how we interact with each other, what strengthens certain behaviors, what gets us to stop other things. Those principles are working whether we've identified them or not. So for me, learning to be a behavior therapist has helped me just get more precise and harnessing what's already happening all the time. The sun is always shining. How do I turn it into a laser beam? It's kind of that sort of the experience to me. So that's part of what I'm going to talk about as we go through this. Okay. Now, in dialectical behavior therapy, if you're not familiar with it, one of the ways it frames the treatment is that you have to look at what is treatment supposed to do. In other words, the functions meaning what's supposed to happen here? What's the purpose of this? The overall function is to help the person get a life worth living. But to do that, what do you have to do to get there? And so the framework of it includes these 5 functions. So we look at the fact that a person, if they're in hell, are disordered, are suffering terribly from the intensity of their emotions and how to manage them, then we have to have something that is able to get them to increase their capabilities, to increase new learning. The other thing is something that we have to have things in there that help motivate them to try these new things, to not give up. Like Adam says, don't give up, don't ever give up. And Adam works his butt off, I can tell you this. He does not give up. So we have to have treatment modalities that do that. The other thing is we know that what you learn in the room with me or with your teacher will not translate out to the real world or out to your world where it matters unless we help you figure out how to get it there. So we talk about generalization. The next thing is in DBT, all DBT clinicians realize that they have to be better at what they do, that they need to be able to be effective, to practice with fidelity. And so we have to have ways to do that. Oh, sorry, I keep moving around, but I'm not moving far enough to put that thing on my body, this thingy. Okay, maybe I will. And finally, structuring the environment. How do we get people to live in environments that actually help them, as opposed to environments that may be contributing to their disorder? So we've got to figure out a way to do that. Well, I'm going to show you where pharmacotherapy lies with that. So pharmacotherapy lays in this function here. I want to use, if I'm going to use medications with you, I want to be sure that the medications I'm using are helping you acquire new behaviors, new learning, and helping you integrate. And God forbid that the medicines I give you are actually interfering with you learning, as many do. So you see how I'm thinking about it as I do that with my patients? And so we talk about modalities, and you can see on here, pharmacotherapy. I guess I'm my pointer. I know there's a pointer in this. Is all this equipment? Oh, God. Which one of these is the pointer? The green one? Ew, look at that. Cool. All right. Even I could figure that out. So what we mean by this is, if this is the function, what it's supposed to do, how do we engage in doing it? So I've got pharmacotherapy there. So I just wanted to frame this in there. A lot of people who know about DBT, everybody gets some sort of skills class or skills training, which is also for enhancing capabilities. But this is where I'm acting when I'm prescribing medications. All right. The other thing that I just want to point out is enhancing therapist capabilities and motivation. Oops. Uh-oh, what did that do? Oh, cool. All right, here's this right here. If you're a DBT practicing pharmacotherapist, you're also on a DBT consultation team. So in other words, in that 524-page manual, there's all kinds of strategies and principles for a clinician to use to be effective with the individual they're trying to help. And so even if I'm in a 30-minute medication meeting, I'm still bringing all of those to bear. And to be good at doing that, I depend on getting consultation from team members to make me that much better. So those are the ways that you're going to see a pharmacotherapist like me practicing on a DBT team. Okay. And this is just a reminder, if you don't know, that, and this is also unusual sometimes for some physicians, the primary therapist works with the patient to run the case, and everybody else on the team works for them and the patient. So if I'm not the individual therapist, as the prescriber on the team, I defer to the primary therapist in terms of the overall case formulation, the hierarchy that they're working on, what they're targeting. And it's tricky because in psychiatry, even with liability issues and things like that, there's all who's in charge of the case. You know, that's legalistic things. Phenomenologically, I work for the primary therapist and the patient. But the primary therapist is in charge. And so that's also a principle that I may touch on in terms of how you manage some of the things that happen in a pharmacotherapy session. All right. Okay, now, this is we're getting to actually what do you do in the sessions. And this is really important, is there is a hierarchy of behavioral groupings that I pay attention to in a session, and that some become more important than others in terms of if they're happening, I address them first. And it's very interesting how that plays out. So for those of you who don't know, I'm first going to go ahead and show you the standard hierarchy. For the primary therapist and in any individual therapy session, so this is just in an individual therapy session, the therapist is paying attention in this order. There's been any life-threatening behaviors, they address those. Above any therapy-interfering behaviors, above quality of life. So if someone's cut themselves or had a suicide attempt that week, that takes priority over the fact that they didn't do their homework for skills class. If this is okay and they didn't do their homework for skills class, the therapist makes sure they touch on that. And then quality of life is all those other things that make you miserable. The PTSD symptoms, the drug abuse, the everything else. And in that, you increase skills. Now, if you switch over to the pharmacotherapy session, it changes. Because remember, I've got a primary therapist dealing with those things. So what happens in the office with me is slightly different. Obviously, if something is going to destroy that meeting, I've got to take care of it. We'll talk about each of these. But then I actually, in this order, decrease symptoms known to effectively manage. I'm actually constantly looking at what is it that you say you're suffering from, and will these meds do it? And then the next thing is I'm looking at health-related things, and then the last thing is actually pharmacotherapy interfering, which some people could be counterintuitive in the sense that you think, well, if they're not taking their meds, it's the first thing you're all over. I have to tell you, this really works. You almost never have this by the time you're done doing these. And I just have to say, Charlie Swenson's here, and Charlie is really the person that I spend a lot of time talking to and learning these targets, so I just want to make sure everybody knows that. Being one of the other psychiatrists who practice this, you know, you've spent a lot of time thinking about this, and as has Marcia, and I'll have to say, it's fascinating to me how little work I do on this because of how I'm doing that. So that's an important piece of this. Let me go over each one of these. All right. Here's what I want to say about targeting. The reason we use a hierarchy of behavioral targets is you have an individual with borderline personality disorder, all the parts are there, they're all over the place, some of them you need, some of them you don't, right? How are you going to frickin' organize this so that they can drive a car out of hell? Okay, this is the hell, right? And you got to make a car and get out. And you know what? The thing is, as people mentioned this morning, I am privileged by being a pharmacotherapist to treat people who there is no way, even standing on their heads, that they can meet the criteria for borderline personality disorder anymore. And I get to still see them because every 3 months or no, we need to check their antidepressant. Oh my God, it's such a privilege. Such a privilege. So I just wanted to say that this is what we're taking this and we're going to build a car. All right. So let's talk about the first thing. Things that are likely to destroy therapy, meaning the pharmacotherapy session, is obviously if someone's about to kill themselves, medications don't work in dead people. So it's not like you're not going to deal with that. What's interesting about that, if you're working on a DBT team, is that even if you have someone where you're doing a risk assessment and management protocol, because you have to right there in the moment, if they have a primary therapist, the principle is I'm trying to get them back to that primary therapist to really help manage the details. So for example, I'm going to try to put in examples from patients here. I was thinking about this as I was looking about it is I have a patient who I'll call MK who has terrible bipolar disorder, dissociative identity disorder, post-traumatic stress disorder, and borderline personality disorder and an eating disorder. And you hear all that and you go, oh my goodness, this woman has gone from 80 pounds curled up in a psych ward to married, finished college, have the job of her dreams, her husband's her best friend. So keep this in mind as you're hearing this, okay? And very severe, her bipolar disorder is really hard to manage. And so, for example, a year ago, I had her in my office, and she didn't sleep at all the night before. She dissociated and was driving around and found herself in parks, you know, that aren't too good to be at 3 in the morning. So she hasn't slept at all. She's got, you know, things to cut herself with in the car, as well as a bunch of aspirin to take at the same time. And she's psychotic. She's in a total bipolar mixed state. She's completely psychotic. She wants to be dead. She's in my office. Obviously, I have to deal with that right now, right? You know? So as I'm doing the risk assessment management protocol, she also happens to have her case manager there, and luckily, we can get her primary therapist on the phone. So the team of us, her primary therapist running the show on the speakerphone, we work with her, get something set up, and she and the case manager are good to go. Unfortunately, we had to put it in the hospital, but it was all done with that primary therapist. You see what I mean? It wasn't just me deciding something by myself. That was really important, and that's how I've worked with MK, and she's very connected to all of us on the team. So that's an example. But that's not the main thing we do in pharmacotherapy. It's just obviously you can't get anywhere. You know, the other things I think of is people like forging your scripts or things that are just going to say, look, this has got to stop. I haven't had that problem, but I do know people do, or people getting aggressive. And I do have a patient who has severe developmental disorder who has tried to clobber me a couple times, but she's a sweetheart, and we've dealt with that. Okay, she is. Actually, what she and I figured, because she's on the autism spectrum, we actually figured out that no one had ever showed her how to use FaceTime on the iPad. So now we FaceTime, even if I'm sitting downstairs in the office at our group home. It's great. And she like talks and talks and talks, so we're good. We're good. Okay. So here's where the first step really starts, is decreasing the specific symptoms known to be affected by medicines. And this is where precision becomes important, and really actually breaking down. If someone says they're depressed, I actually want to know what that means and where it fits. And so a couple ways that I do that really help me are first starting with this, as Nicole went over. Was it Emily? Who was Nicole this morning, right? Have I already forgotten? Emily. Thank you, Emily. I knew it was Emily. Okay. Emily was going over the DSM criteria for borderline personality disorder. And one of the ways we look at it in dialectical behavior therapy is categories of dysregulation. So that if you have a pervasive dysfunction of emotion regulation, you're going to have interpersonal problems, you're not going to know who you are, and your behaviors, behaviors usually occur either because you're dysregulated or you're attempting to regulate, and sometimes you can't think straight. Oh my God, that's true of any of us, even if we don't have borderline personality disorder and emotions are aroused. That's just the way the brain works. So my patients and I will actually go through all these categories and figure out what are we exactly targeting here, and whether there's a med that helps it, that could help it, or whether there's things that maybe have been prescribed to them that are interfering. Does that make sense? So, for example, if we look at this, recently MK was in for a pharmacotherapy session just this past Monday. And for years, we actually targeted this. Very severe stuff years ago. Many suicide attempts, a lot of self-injury, the dissociation really interfered, et cetera. Now, this week, last week, she says to me, and this is the first time this has ever come out of her mouth, and we're standing in my office and she's dissociating, so I have her on a balance board, and I'm holding her hands and making her balance, and she's laughing because she's dissociating, so we can't talk about the meds. So she stops dissociating, and she looks at me, she goes, okay, I'm ready. I really do want to work with you guys on decreasing dissociation. So right now I have somebody who I've looked at medications regarding this, and now she wants to look at whether the meds can help with that or not, as well as what she's doing with her primary therapist, if even more so what she's going to be doing behaviorally. But I've got an eye now to what she and I are going to be targeting a little bit more closely. All right. The other thing that I use with patients is, so to do that, I go over the symptoms that way. The other thing is the borderline symptom checklist. I don't have an example here, but it's a really handy way of going over with my patients all the different nuances of what you call borderline personality disorder, and we can pick things to do meds around. And then what I do with them is I'll have patients come in with 4 weeks worth of diary cards from their therapist in them, or I'll have them fill out a borderline symptom checklist at the beginning of my pharmacotherapy treatment with them, and then every month or two fill it out again, and we'll actually go over those things together. So this is the other piece of this. I want you to get the sense that I don't just do this once. I'm spending time with them each time saying, where are we sitting? We said we were going to do the meds for this reason. Let's actually see what's happening with those. Does that make sense? All right. So the other thing that I do is, and I'm actually going to show you this. This is one of the handouts that was handed to you this morning. This is Adam's diary card. And so, again, he was happy to use this. I actually both do his pharmacotherapy and I'm his individual DBT therapist, but I wanted to make some points about what we do with this in terms of the pharmacotherapy. So, for example, when it comes to disorders of cognitive dysregulation, Adam also has a head injury, and he has difficulty processing information, so that's something that we're always working on, as well as the fact that his cognitive dysregulation can be intense. Once he gets, the horse gets out of the barn, he starts to believe that everyone, including me, are spying on him, that we're actually taping him. He also has some terrible PTSD that involve videos. So he starts to get into this almost flashback that maybe we're doing what his perpetrator did. And he gets completely down the chute. I call it luge mind. Now, you guys aren't from Minnesota. Do you know what luge is? Do you know? Luge, the luge sled? It's like luge mind, okay? And so Adam has named that, if you'll probably have to look on your thing, he describes that as full force rigid thoughts. That's his word for it, because it's exactly what happens. It'll happen in front of me. It happens in situations that are really hard, really interfere with his life. And so we actually follow this in terms of medications we may be adjusting or not adjusting. Again, I'm not going to say what we're doing for it, but I just want to say that that's what we look at. You know, another thing that he gets is he's extremely vulnerable to his emotions. His emotional vulnerability and dysregulation just, boom, it just goes so quick. And again, the head injuries do not help. He's got, again, very severe frontal lobe dysfunction. And that was acquired, unfortunately, by multiple suicide attempts ending up with anoxia by taking opiate overdoses. It's very sad, and he knows this, you know. So what he came up with for that is, if you look on your column here, urges to, it's actually guns under sensations. It says boat overload. For Adam, he can describe this so well. You know, two people are talking at him, something's going on, it's not an easy situation, it's stressful, and he says he feels like he's in a boat, and people keep getting into the boat. It's a little life raft, you know, a little dinghy, and people keep getting into the boat, and before he knows it, the boat is going to tip over, they're in an ocean, it's a storm, it's just terrible for him. And so this is another way we can look at the medications in terms of mood and affect lability. All right. Now, part 2. This is back to our hierarchy. So now what I've done is I've addressed with my patients what symptoms are we managing. What are these, it's very precise. You're not just throwing meds at people. But it's this kind of notion, and it's the real ethos of it is us doing it together. So now what I want to look at is, okay, we know what we're targeting with these meds or meds that we've taken away. How are you doing? How's your health? In DBT, we talk about please skills. These are the skills that are related to self-management of health-related behaviors and of reducing your vulnerability to being in a state of emotion arousal without being able to control it. Getting plenty of sleep, taking care of your physical illnesses. Unfortunately for my patients, I am really in a tertiary care, sort of outer Mongolia role because I work for DHS. And it's very sad, but many of my patients, nobody comes to me until everybody else has given up on them. And they're usually in the committed system. It's a nightmare for these people. And so by the time they come to me, they have all these health-related problems, many of which are part of having been in institutions where you get no exercise and the food sucks, all the way to the side effects of the medications. So for example, I have CC, someone I'm going to talk to you about, who just called me last week. She was so excited. I'll tell you what she called me about. Anyways, I've treated her for quite a while. It's been over 4 years since she had any drugs. She was a meth addict. It's been at least 3.5 years since she's had any aggression, self-injury, and suicide attempts. She's now working. She's got a permanent home. She's studying to be a peer support specialist. But she is horribly obese. And she's quite embarrassed about this, not to mention that some of the meds that she was given added to that, right? So she and I are spending a lot of time these days working on helping her find ways to exercise, eat healthy, and lose weight. So we'll actually assess what she's eaten the week before and figure out together where she can make changes. And she was so excited. She called me the other week. She goes, she left a message. She said, "You can't believe it. Okay, so when I went to Walmart, instead of getting chips and all that, I got hummus like you brought to me." I gave her hummus one day, and she was like, "Oh, this is really good." I said, "I know." So I got hummus and carrot sticks, and then I got on the scale, and I knew I had gained weight, but instead I'd lost 7 pounds. And so another thing that we've done in my sessions like with her is in my pharmacotherapy session, we've planned for teaching her mindful eating as part of the session. So she'll come in with a healthy lunch. I'll have a healthy lunch. We inspect each other's food to see if it's healthy. And then I teach her how to sit and mindfully eat. So to me, that is absolutely part of pharmacotherapy. Do you see? Because my job is to increase capabilities. And you are more capable if you're healthier. So are you following kind of? It's hard to know because I know we're not talking to each other right now. So, all right. this, you know, Cece's another example. She has terrible obstructive sleep apnea. So early on, I was ruthless in getting her to a sleep study, ruthless in her getting a CPAP machine, and then she and I, in the group home she's in, worked on, we did behavioral analysis of every time she didn't use that frickin' CPAP machine until we figured out what to do, including getting her back to the respiratory therapist for a better way of sticking it on her face. She uses it every night now. I mean, this is a woman, again, she has a bipolar disorder, terrible PTSD, substance dependence, and borderline personality disorder, which is much more not there anymore. And, you know, sticking that mask on her face was a big deal. We had to really expose her to it and get her to do it. And I'll tell you, it's made a huge difference. Getting a good night's sleep is like nobody's business if you have a mood disorder. All right. This is just to show you the other side of the card if you haven't seen them. You've got them in there. I know it's hard to see these, but I will actually, when I have them bring in like 4 weeks worth of cards, I'll glance down the skills, and I'll be particularly paying attention to these please skills here and seeing how often they're using those. Okay. So finally, something that I actually don't get too often is people not taking their meds, although MK is the master of finagling, as she says. So we often work on medisets and things like that. But the reason I put this in here about standard cognitive behavior therapy is this. Standard cognitive behavior therapy DBT is a cognitive behavior therapy. And so just because I'm doing pharmacotherapy doesn't mean I'm not always figuring out what is it that's getting in the way and actually doing what we call as a meta-analysis, a kind of a broad macro look at if you didn't take your, or like with Cece, you know, if you didn't use your CPAP, let's do a behavioral analysis on what got in the way. And we try to look for patterns, and then we come up with solutions. And so in these solutions, we figured out for her, she had to expose herself to the mask. So she actually started by wearing her CPAP mask on the couch in the day for 30 minutes. And then it just took a couple times, and she was ready to go. So you're still doing these therapeutic interventions, even though it's in the service of increasing their capabilities through pharmacotherapy, you know, better living through chemistry. I'm all for that. But I want it to be actually better living. Okay. The idea here for all of this is this. So you've got, remember we started out, you've got all those parts. You've got everything you need in your junk pile to have your life, to be able to drive out of hell. And you have things you don't need yet, but you can't figure out whether you have them or not unless you dig through that pile. And then some of those parts you need and some of them you don't. I mean, the idea here for me is to build this little go-kart, which I love. Drive the person out of hell. That's what I'm doing with them. That's what the two of us together want to do. And by the way, YouTube says this only costs $15 to make. But I mean, it really is. All of this, all of the energy that my patients and I do are get you the hell out of hell, and not just get you out of hell, but start to develop this beautiful life. You know, it's like these patients that I see that no longer have borderline personality disorder. I mean, honest to God, sometimes I feel like I'm with these advanced spiritual people. I've got a couple that, like one of them just the other day, Chris, who's also she's an advanced cardiac life support nurse. She's brilliant. 40 years, literally, of devastating depression, interacting with the borderline personality disorder. She's been, like, amazing the last 5 years. And so what we're working on now is sex, because her life would be better if she had a partner and could have good sex. I mean, come on, ladies. All right? Let's be real here, right? So, no, but it's true. I mean, this is a health-related thing. And I couldn't believe it. So we've been trying to figure out, because she has, on the spectrum of libido, she has a low libido. So I sent her out to watch sort of racy movies that didn't do her any good. So I said, well, let's talk. She has a lot of endocrine problems. I said, well, go talk to your primary care, because maybe it's these endocrine things. Do you know what her primary care doctor said to her? I mean, I shouldn't slam other doctors. And she's so forgiving. She said, I think she was just not in a good mood that day. She said, you're 61. What do you expect? No. And Chris is so good. She said, she's been like this before, really invalidating, and I totally get it, because sometimes she's busy and she just doesn't think. But Chris is driving out of hell, and she's got an appointment with a friend of mine who's a human sexuality expert to help us figure this out, because we're going to get her not only out of hell, but really having the good life. She's going to be on that go-kart. Maybe she's going to be on a Harley. Okay. So let me finish up with trying to tell you about the 524 pages in the treatment manual. And again, some of you are DBT practitioners, or you get treated this way. You know, in all of my sessions, I am weaving these three principles that uphold the strategies and principles of DBT. Is I want to be able to be in a place of complete acceptance of where you are right now. I also, though, realize that where you are is hell, and you've got to get out of it. So I've got to have techniques to help you change. And when we're butting heads, I have to step back into what we call a dialectical worldview, and step back into this idea that when we're polarized, and I'm like this, that there's truth in what I'm saying and there's truth in what you're saying, and how do we come to a synthesis? So I'll give you an example of kind of going through some of these things. And in terms of the dialectics, for example, even Adam, the one who generously gave us his diary card, you know, he can butt heads like nobody's business. And then you add the frontal lobe tragedy onto it, it's like, oh my God. And he and I have gone back and forth on how to do this. And we've come up with all kinds of synthesis over the years. For example, according to people in Minnesota, I speak fast. Do I speak fast here too? Okay, well, let me tell you. I grew up in Ridgefield, Connecticut. I lived there till I was 13. Okay, so thank you. Well, I apparently speak really fast in Minnesota, and Adam's brain goes really slow. And we would have these, like, at the end of a session where I couldn't get him out the door. His brain was like he hadn't gotten anything. I mean, we were going at it. On the one hand, I had my limits of this is how much time I had. On the other, his brain wasn't processing. So we came up with an idea that is somewhat unusual for psychopharmacotherapy, but also remember, I'm his individual therapist. We actually changed from an hour-a-week session to an hour and a half. His brain goes slower. Isn't that beautiful? I mean, he's absolutely right. I only have so much time, and his brain goes slow. Well, then what the hell are we trying to force ourselves into something because that's what everyone says, 50-minute hour there, you know. And now, keep in mind that, I mean, thank God I'm in public health. I mean, this is kind of terrible. But if he had insurance and I was in a private office, some big honcho would be telling me I couldn't do it. Well, that ain't going to happen to me. I'm trying to be effective, you know. But things like metaphors also. For example, the use of the boat overload for Adam. Adam, really, the one thing we butt heads, when he and I can find a metaphor, it's just perfect. So that's the dialectical part of this. I was thinking about these two things to give you an example of, and let me watch my time. I've got about a minute. Let's see what I got for this. This happened on Tuesday. On Tuesdays, I go to a residential, state-run, inpatient locked chemical dependency unit. Again, so if you can imagine, nobody gets to these places unless a lot of crap has happened. So, and I'm a consultant there on Tuesdays, and JJ, who has a severe neurodevelopmental disorder, terrible meth addiction, some sort of mood disorder, not otherwise specified, that seems to be related to the neurodevelopmental disorder, and borderline personality disorder. And he goes AWOL last week and ends up using meth again, okay? So he comes, I get a call from his mom on Tuesday. She's in the car behind an ambulance following him because thank God he called her. I mean, his mom loves him dearly, and we've been working very closely with his mom and him. He's like 21 years old, so he's really pretty young. And so the acceptance part of this I wanted to tell you about was this, because it struck me as I was thinking about this talk this week. So we're sitting here, myself and JJ, and first I go see him, and he's in the gym with his counselor because he's so, you know, he's just coming off the meth. He feels like crap, and he's frightened. I get him out of the gym. We go into my office. We get his mom on the speakerphone. And the psychologist is with me. So the two of us are with him in that room. He's panicked. He's crying. He feels like shit. And we both grab his hands. I grab one hand, and she grabs the other, and we just press on his palms. And I say to his mom, we're holding his hands right now. She said, oh, thank God, because that's what I did in the ER, and it really calmed him down. I said, perfect. we're holding his hands. You see how that's just the way you are right now? Okay? At the same time, obviously, he feels like crap right now. I've got to get him out of that. Not just with pharmacotherapy, whatever else I can do. So when we were in the gym, before this part where I got him in my office, he was crumped over like this on the bleachers with his CD counselor. I said, no, come on, get up, let's go. And he and I walked, and I'm running like this, and I go, I'm 53 years old, why aren't you running? You know, and as we start to run and walk briskly together, his breathing regulates, and he tells me the story of how he relapsed. So now I can do behavioral analysis, and I'm working on change. Do you see how that goes together? And then dialectics involves things like even what we call stylistics, where you balance your acceptance and your being right there and being radically genuine yourself with things like irreverence and throwing people off balance. Because when we get thrown off balance, if you're polarized, if someone says something funny or something that kind of piques your curiosity, your hippocampus opens. It's really cool, right? So we'd been sitting there holding his hand. He's crying. We're working on trying to get him settled. All of a sudden, he says, I need to go to the psych hospital. Now, psych hospitals for him have been problematic in that they've really reinforced suicidal behavior, because he would start telling people he's going to kill himself, and then they'd put him in the hospital, and so he would escalate telling people he's going to kill himself, and then he would actually try to kill himself, and they put him in the hospital. So we're really trying to break that pattern. And so we're sitting there holding his hand. I got to go to the psych hospital. And I look at him, and I lean close. I said, listen, I know those guys over at Mercy Hospital. They ain't going to hold your hand. And I do. I've got 3 colleagues. I work very closely at the psych hospital. And he goes, oh, right. So I'm going to actually stop there. There's some other couple slides, but I think that we do want to have time for question and answer. And I can see Emily, who promised I would No, I'm good. Do you have some questions? So why don't we do that? Because I don't want to get off schedule because there's a break at 10. And there's nothing worse than people not getting their break on time, correct? Does it, come on. 10 minutes. Who knows where you'll drive to in that 10 minutes? All right.
All right. Well, thank you very much. We're going to ask if you have questions to start passing them to the aisles. You'll see that there are volunteers that will pick them up and direct them up here. We already have a couple of questions. So one of them, though, is asking about medications. How do you feel about yes? How do you feel about answering a question about medications?
How do I feel, or will I?
How about both?
No, I will.
All right.
It's just that sometimes it can be out of context.
Yeah.
Anyways, go ahead.
So the question is, do you have any recommendations on medications on how to manage sleep and food dysregulations other than stimulants?
Yes, that definitely is. I have to know the patient. Can you read it again? Other than stimulants for like overeating? Does that mean like overeating?
They just say sleep and food dysregulations.
Oh, I'm supposed to, he's that guy in the back is waving. You mean, I got to do this, right? Okay, sorry. Boy, that's just so general, I'd have to know the patient. I mean, here's the issue. If I have someone with dysregulated eating or dysregulated sleep, we're doing behavioral analysis of what that is. And then I'm going to drive the medication towards what particularly for them. So I really would have to say I couldn't give a generic recommendation, but it's more what I want to get you this idea is that this idea of understanding how to do behavioral analysis will help you figure that out. Okay.
All right.
But you can meet me in the back afterwards and tell me what you really mean.
So in the model that you present, do you think that excessive smoking and nicotine use can be treatment interfering?
Well, treatment interfering refers to behaviors that interfere with you as the clinician delivering treatment. So it's either things that you do that bug the patient, or it's things they do that bug you. So if someone was smoking in my face in my office, it would probably bug me. That being said, it is a health-related problem. And so, for example, CC is someone who I was scared crapless. I'm trying not to swear. That's right, I'm on the East Coast, it's okay. I get in trouble for this all. I mean, Charlie, don't you have that story of when you said fuck in Minnesota, that's the only place they've told you, like, the only place you get credit at all. Yeah. So anyway, CC, for example, has worked on giving up smoking, and we finally decided to let her do Chantix, which of course can make people nuts, even when you're not nuts to begin with. And bless her heart, we walked her through the nuts at night by changing some of her meds at night to help her with how it made her kind of goofy. And it's helped, and she's stopped smoking. Now, on the other hand, I have another patient who came in with cigars. This is what gave me the idea to give my son a cigar, because him and his dad came in, and they know this really good cigar shop, and they're pulling out these cigars at our meeting, and I'm like, oh my God, smelling them. And then all of a sudden I realized that we could all be arrested because it's state property and it's against the law to have tobacco on it. So that would be therapy interfering if I, like this security guard had come in and we were all arrested. All right. I don't think this is what they expected, but.
I'm sure it was very informative. I actually have a question. We have family members in the audience who we welcome today, and they have a question that you might be able to answer to help clarify some of the words that we use to describe some BPD symptoms. They're wondering about if you can explain the difference between parasuicidal behavior and suicidal behavior.
Okay, so in the field of research of how do you call what behaviors, it used to be that parasuicidal behaviors were any self-injury without the intent to die, and suicidal behaviors were self-injury in which the intent was to die. So it had to do with the intent, probably more phenomenologically precise, and what is used more often now in the literature is suicidal self-injurious behavior and non-suicidal self-injurious behavior.
We have actually a couple questions. I'm going to try to merge into one question.
Good luck. Synthesis.
Synthesis.
Yes.
We have some questions asking about if patients can't tolerate the medications, or with polypharm prescription being so widely common with BPD. What are your approaches that you use in those cases to deal with patients that maybe don't want polypharm because they've had bad experiences, or that want to decrease the number of meds that they're on because they don't want all the side effects, or that simply can't tolerate the medications that maybe are going to help reduce the specific symptoms that they're reporting?
Yes, that's what I do. Okay, so on the other hand, I'm like the Annie Oakley of polypharmacy, and I know if I have some psychiatry colleagues here, you might be aghast. On the other hand, again, this gets back to the precision and the understanding symptoms. So it's not only understanding the symptoms of borderline personality disorder, but me and the patient and I looking at the side effects and deciding, you know, what are the risks and benefits. And there's something in distress tolerance that we use called pros and cons. It's also a commitment strategy. It's very similar to in motivational interviewing payoff matrix. So it's not uncommon for me in a session to get, I always have a whiteboard, is to get on and say, okay, I really don't want to take this Abilify, for example. Oh God, I just said a med, aripiprazole. Okay, so we've already looked over the symptoms we're addressing as to why we might use this. So we'll write on the board, we'll put use aripiprazole, pros and cons, don't use aripiprazole, pros and cons, and we'll actually go through a matrix. It's actually a dialectical assessment of using whatever the different medications there are. So again, it just, I'm totally in favor of helping people have the most bang for their buck with the least amount of side effects. But again, it's this precision of doing it, of how I go about it is what I'm trying to get across.
So keep handing in the questions if you have them. If I don't ask them, we do have a panel discussion at the end of the day where a lot of the questions that might be relevant to multiple speakers will be brought up then. You have a question about how do you handle clients who take their medications wrong? Like maybe they take too much at a time and then they run out before they should, or the in-demand. You want me to come up? All right.
Okay. All right. So Emily, what is the deal here? What do you mean that you sort of took the Geodon with a cracker but not a meal?
Well, I didn't really feel like eating right then.
Okay, all right. So Emily, we've talked about this a gazillion times. You actually have a problem where you don't often feel like eating. We've also talked about eating being food because you need to weigh 124 pounds or you get psychotic, correct? I'm skipping ahead. Yes, you do. You believe me, it's been beaten into your brain, Emily.
Yes.
This is MK, by the way.
Okay.
All right, so here's the deal. I want you to take it twice a day, and I've told you that just even a cracker isn't going to get in your system. So let's figure this out. When you get up, are you eating breakfast?
Well, if I have to take it twice a day, then that means I'm going to have to eat twice a day.
I know. I realize this is a problem, but just remember, we're aiming for 124, so there's no psychosis. Okay, remember. Okay. All right. So there's something that I know, because you and Bev have been working on the eating. She said that you've been tracking eating lunch every day. You've been having like yogurt and a little salad.
Yes, that's right.
Yeah. Okay. So why don't you just take it during that time?
I guess I could do that.
Yeah, and then because at night, your husband, Jeff, and you, the one thing we all love about you having married Jeff is you have to eat dinner.
That's true.
Not that he isn't a great guy, but we're all thrilled that you guys sit down for dinner together every night. Because I'm not against even if it's closer together than morning and evening. The main thing is that you're getting it with lunch, which I know you're eating, because Bev will kill you if you're not, and Jeff and you have dinner together. So what do you think about doing that?
I think I might be able to do
that.
I'm
just trying. Do you see what I mean? I don't know what I would do with any of these except assess the patient and together us figure it out.
Yeah.
Yeah. Otherwise, I just slap them around and
And
No, I don't. I promise.
We've actually had a couple of questions about this, and
we just have a minute left.
We have a minute left.
Yeah.
So we've had a couple questions about people asking about ECT as a supplementation to the psychopharm that you're prescribing.
They want ECT?
They're asking, I think, if you have experience or if they can't tolerate the medications, do you recommend that?
It depends on the patient.
Exactly.
I have patients right now on maintenance ECT, and I have patients who I coach them in every way, shape, and form to run like hell.
Yeah.
So it depends. That's the famous DBT answer. It depends.
Exactly.
So,
well, thank you very much, Dr. Witterholt.